Good afternoon, everyone. My name is Dr. Trish Sipley, Director of Professional Education and Research for the Central Jersey Family Health Consortium. I would like to welcome you to our series of webinars focused on Maternal Health Awareness Week in New Jersey. This presentation is one of 4 being sponsored by Central Jersey Family Health Consortium. As for what you might have heard this morning during the First Lady's strategic plan, maternal and infant health is a priority in our state. Today's presentation will be what's data got to do with it. Unfortunately, Dr. McFarland could not be with us today as a co-presenter. It is with great respect, however, that I introduce Carly Warman-Ryan, MA, BS, who is a Senior Planning Evaluation Specialist for the Central Jersey Family Health Consortium. Carly received her bachelor's in Anthropology and Sociology from Virginia Commonwealth University and her Master's of Arts in Anthropology from the University of Wyoming. She is well versed as a data analyst who has collaborated on numerous projects throughout our state. In addition, Carly leads the Fetal Infant Mortality Review Committee, charged with reviewing infant and maternal deaths in New Jersey and making recommendations for policy and practice change. So let's get started.
Hi, Trish. Thank you. This is Carly Warman-Ryan, and I am a Senior Planning and Evaluation Specialist in the Department of Data and Evaluation. I also have been coordinating the FEMUR program recently, and I will be presenting for Dr. McFarland. Here you can see our mission, which I imagine everyone knows by now, that our mission is to improve the health of women of childbearing age, infants, and children in the region throughout the collaborative efforts of member hospitals, providers, and consumers. So, plan for today. I would like to talk about why data is important, how we use what we know, largely the data, to impact change, define social determinants of health, talk about how social determinants play a key role in birth outcomes, and discuss how programming is determined based on available data. Here we have a graphic representation of using data to impact change. This is a strategy map oftentimes used to determine how to allocate resources to address a problem. The big problem is something that could take years to have an impact on. For example, changing rates of cardiac-related deaths could take a generation to show an impact. The intermediate problems are those that if you can fix them, you have a good chance of impacting the big problem. The short-term problem is what programs typically address, and these are the things that we can measure quickly and affect change in short periods of time. Next, please. So an example. Here's a real-life example of using the strategy map with infant mortality. In order to decrease infant mortality, you must decrease the rate at which babies are born with genetic malformations, low birth weight, and preterm birth babies. We come in by addressing the short-term problems that will have an impact on addressing the intermediate-term problems and ultimately make a difference in the big problem. For example, we at CJ provide services in the community that include teen pregnancy prevention, tobacco cessation programming, a community health worker program that assists in getting women into care. These programs may have an impact on reducing preterm births, and by reducing preterm births, we can thereby reduce infant mortality rates. All of the things that you see here fall under the umbrella of data. We collect data of all these aspects. And without this data, we cannot accurately target programs that will have the largest impact on our communities. Next. So infant mortality is a very good measure of community health, considered to be a sensitive index of population or community health. The national infant mortality rate is approximately 6 per 1,000 live births a year, and the US ranks 35th internationally for infant mortality. We find that Blacks have a higher mortality rate, 2 to 3 times higher than whites in infant mortality. If we looked at our Black non-Hispanic infant mortality rates alone, we would be similar to Thailand, or I'm sorry, similar to Thailand and China, and our international ranking would be approximately 73. And these poor international rankings are not driven by Black infant mortality. We find that white rates are also higher in most industrialized nations. Here you can see a map of infant mortality in the United States. The darker colors have the higher concentration of infant mortality. You can see in New Jersey, and this was 2017 data, in New Jersey, we are in the lowest category there, between 3.7 and 4.6. However, it's important to know that we have very, very large disparities in our infant mortality rates in New Jersey. Next slide, please. So here you can see by this chart, using 2017 data, that Black women or Black babies have an infant mortality rate of 2.3 times that of white non-Hispanic folks. Next, please. Here you can see also visually using the same color coding, with the darker areas being the higher numbers. Just the state and how it falls out. Some of the highest numbers of infant mortality have been in Cumberland, Camden, Atlantic, Salem, and Warren counties, and in our region, Mercer County. Racial disparities in rates are also high in these areas. Next, please. Again, this is a visual representation of what we have seen with the change in infant mortality over the years, starting from 2000 to 2018. You can see that overall there's a general downward trend, but in the last about 6 years, we're seeing a little fluctuation, but it does appear to be pointing down at the end of that time frame again. So you can, I think, very easily, looking at this, see the difference in the race and ethnicity and how it affects infant mortality in New Jersey. Next slide. So let's talk about social determinants of health and the push for health equity. Social determinants of health are the economic and social conditions that influence individual and group differences in health status. Social determinants of health play a huge role in maternal health. One of the biggest ones that we look at is race. Race is a group of people who share a set of characteristics, typically but not always physical ones. The changing dynamics of the population impacts health. So we are seeing an increasingly non-white Hispanic population. Hispanics are now the majority minority group. And you can see there the numbers of the different races for 2014. Racial disparities are evident and enduring, and a good chunk of these disparities are due to these socioeconomic status differences. And we'll talk a little bit more about that. And here you can see the number and percent of folks at or below the poverty level the year the data was pulled for a family of 4. Next, please. Health disparities. Disparities in health outcomes among groups of people. We pay attention to the root causes of health inequities and health disparities, particularly the health determinants, which has been a principal focus of Healthy People 2020. Minorities, especially Blacks, experience worse health than whites. Blacks have lower life expectancy and a higher prevalence of adverse birth outcomes, such as preterm labor, low birth weight, fetal loss, infant mortality, and maternal mortality. So let's look at our births in New Jersey and see where we stand. Next, please. So here you can see these are 2019 deliveries, live births in New Jersey. So you can see in the central region, we have about a third of the deliveries in the state, a little bit more than that up north and a little bit less than that down south of us. The birth rate has been declining for the last few years. Not dramatically, but enough to show in the numbers, which again is something that we look at and we will take account of when we look at finding funding and using data to prove our point that we need funding for specific programming. So here you can see in our region the number of births by county. You can see that the highest number of births is in Ocean, with Middlesex not too far behind, and our lowest number of births is in Hunterdon County. These charts are taking a look at racial makeup by births, by regional births in the region, and socioeconomic status for 3 different points. So in the chart on the left, you can see the difference in representation of different races. For example, the black bars are Hispanic, and we see that the largest population of Hispanic is actually in the southern portion of the state. And then for Black women, we see that the northern part of the state has the highest percentage of Black women, and we are at 8.2%. Down south, they're at 14.8%. So that just gives you an idea of the racial ethnic composition of the different regions. And then in terms of socioeconomic status, and I believe that this is statewide. So about half have less education, a high school degree or less. 60 or so percent are unmarried, and Medicaid covers about half of the deliveries in the state as payer. Here again, we have different maternal health indicators, as we call them, that we look at to judge the quality of care that's being given and address certain problems in the region. So no prenatal care, we all know, is a problem. You can see here that there is a much higher rate of no prenatal care for Black women than there is the total line, than the pink line or the white line. We also have WIC during pregnancy by race. So you can look at the different numbers there in terms of the highest utilization of WIC by race over the last 4 years there. Next, we have the delivery method. Black women who gave birth in 2019 experienced lower rates of vaginal births compared to the statewide average, and white women who gave birth, while rates for primary C-sections were higher. New Jersey does have high cesarean section rates, which is something that has been given a lot of attention to recently, and there are efforts underway to decrease C-section rates here in New Jersey. Next slide, please. So the C-section rates have remained pretty steady statewide, from 35 to 34%. In 2019, the number of C-sections or percent of C-sections to white mothers was approximately 31%, and the C-section rate to Black mothers during the same period was 36.7%. So we do see a little difference in method of delivery when looked at by race. Preterm birth. Preterm birth is another adverse outcome, infant outcome, but also maternal income when we look at preterm delivery. So here you can see the preterm births over time from 2000 to 2017 by mother's race and ethnicity. And again, you can see that the line up top for Black women is significantly higher than the other 3 races presented. So social determinants of health. As I mentioned earlier, social determinants of health are economic and social conditions that influence individual and group differences in health status. So we are looking here at economic stability, social and community context, neighborhood and environment, healthcare, and education. So social determinants are conditions in which people are born, which they grow up, where they work or are occupied, where they live geographically, and their age. The wider set of forces and systems shaping the conditions of daily life include such non-medical factors as employment, income, housing, transportation, childcare, education, and discrimination. You can go next. So different dimensions of socioeconomic status and health. These are the common ways of looking at measuring social economic status. The measures are interrelated but distinct. So here we see education, income, occupational prestige, and we see that these links are context dependent. And you can read for example, the poorest people live 6 years longer if they live in New York City versus Detroit. And that there's evidence that education has become more strongly linked with mortality over time. While income and occupation prestige are strong predictors of health, educational attainment is an exceptionally strong predictor. Even if in countries with low inequality and many social safety net programs, such as Scandinavian countries, higher education still equates to better health and longevity. There's also evidence that the link between education and mortality is becoming stronger with time. So why education of all these factors? Well-educated people are best informed about the merits of a healthy lifestyle, including exercise, not smoking, moderate drinking, and knowing the advantages of seeking preventative care. They're also paid more, providing and report more satisfaction with their jobs and have more perceived control over their lives. While education prevents the onset of disease, income is projective of its progression. By every measure, American adults with college educations enjoy better health than those with lower levels of education. The better educated feel healthier, have less difficulty with common activities, feel more frequently to be thriving, often suffer less aches, pains, and malaise, less often feel worried, depressed, and carry fewer diagnoses of threatening or debilitating chronic disease, are expected to live longer and probably will live longer. Next chart, please. I'm actually going to skip past this one. If you could go one more. Poverty and health. So lower economic status equals the poorest health. Lower socioeconomic status equals the shortest life. Life course perspective talks about the long arm of childhood and fetal origins hypotheses. We see areas of increased risk exposure. For example, Flint in Michigan, where they've had quality of water concerns. There we see a risk exposure that has to do with physical, chemical, biological, psychological, economic, and lifestyle. People in poverty have the worst and lowest life expectancy, and this applies across the lifespan from womb to tomb. Life course perspective looks at experiences from birth to death and how risks and resources accumulate to impact health. In short, the life course perspective takes the long lens on examining the etiology or origin of disease. For instance, life course sociologists often talk about the long arms of childhood, that social factors experienced in childhood influence likelihood of mortality as an adult. And the field of ACEs, or adverse childhood experiences, has been blossoming recently as a way to look at toxic stress and conditions during childhood that may impact chronic or other disease in adults. Next slide, please. Okay, so neighborhood disadvantage. So features of the environmental impact health may have would be physical environment, their surroundings at home, work, and play, services provided to families, sociocultural aspects, and reputation. Here we see long-term exposure to stress. We see decreased cortisol excretion and limited ability to respond to inflammation. A daily environment of disorder, crime, and danger were associated with feeling run down, hopeless, sad, tired, and depressed. Crime, incivility, and harassment can take a toll on health. People in rundown neighborhoods in Chicago were found to have lower levels of cortisol secretion that decreased energy and the strength of the body's ability to respond to inflammation. Asthma is a good way of, asthma is one of the chronic conditions that is well looked at within the neighborhood and community perspective. Next slide, please. the education advantage. Here you can see the preterm birth rate by race among college educated women. You can't see the key here, but the higher line is Black non-Hispanic, and I believe the red line should be white non-Hispanic. So we see, even with congruent or the same education amongst women of both races, we still see that the preterm birth rate is significantly higher in Black non-Hispanic women. 1.6 times higher, as a matter of fact. So again, here, this is looking at the same thing in a different way. And you can see this is preterm births by education. So we're essentially ruling out education in terms of infant mortality and preterm birth as being the driving factor, because we can see that when controlled for education, Black non-Hispanic women still have more adverse or worse preterm birth rates and other adverse outcomes. Next, please. Psychological stress hypothesis. Although there have been many different theories as to why Black women have poor birth outcomes and higher infant mortality rates, current research suggests that stress is the primary factor affecting these adverse outcomes. Black women face discrimination from a young age, which leads to chronic health conditions associated with stress. We can see the stress associated with discrimination leads to higher prevalence of hypertension. Stress process theory integrates the macro and micro perspectives. So many stressful experiences don't spring out of a vacuum, but can be traced back to surrounding social structures and people's location within them. Next, please. So stress, what happens to the body? In a short time frame, we talk about the fight or flight, and that is the body's way of preparing itself for vigorous effort and possible injury, that increased adrenaline. In the long term, we see increased stress reactivity, meaning a higher rate of reactivity to stress itself, an inhibited immune system, because again, as we were speaking before, we see lower levels of cortisol, increased inflammation in the body, increased blood platelets sticking to arteries, increased glucose, appetite dysregulation, and satiety dysregulation. Next. How is society linked to stress? One of the key points of Emile Durkheim, who is an infamous sociologist, was that stressors can occur on the societal level, not just the individual or community level, but also on a societal level. One modern example of a stressor that occurs on a macro level is economic recession. So here you can see some of the conditions that have been related to economic recession: heart disease, stroke, kidney failure, mental illness, infant mortality, and violence. Back in the late 2000s, when we had a recession, there was an increase in shaken baby syndrome in the state of New Jersey that was related to stress. And then as a result, there was education done on abusive head trauma and shaken baby. And I'm not sure if anyone on here actually participated with the program, The Purple Period of Crying. So that was directly linked to a change in violent activity that was created by stress. And then we did see, after some education and after that time and the recession improving, that those numbers went back down again. Next, please. Types of social stressors. Again, the stress process theory says that the impact of one type of stressor cannot really be discussed with reference to others. So you may have a life-changing event, which is a discrete event that requires change, and then you may have chronic stressors, which develop slowly and often insidiously. So threats, demands, structural constraints, under-reward, complexity, uncertainty, and conflict. Things like daily hassles, non-events, trauma, and macro stressors are all part of this stress complex that is having an impact on health and maternal child health outcomes for women delivering babies. Next slide, please. So what do we mean by equity? For health equity, we want the attainment of the highest level of health for all people. Health equity means efforts to ensure that all people have full and equal access to opportunities that enable them to live healthy lives. While health inequities are differences in health that are avoidable, unfair, and unjust. Health equities are affected by social, economic, and environmental conditions. Particular attention is paid to groups that have experienced major obstacles to health associated with socioeconomic disadvantages and historical and contemporary injustices. Promotion of equal opportunity for all people to be healthy and to seek the highest level of health possible. And then we see distribution of socioeconomic resources needs to be healthy in a manner that progressively reduces health disparities and improves health for all. And we have focusing on continuous efforts to maintain a desired state of equity after avoidable health inequities and health disparities are eliminated. Here you see the difference visually between equality and equity. Next slide, please. So what does equity look like? Back to talking about data. So equity would look like this chart would look, where that line up top, which is the Black non-Hispanic, and the line down below, which is the white non-Hispanic, or the group that's doing quote unquote the best, that those lines would meet and we would see one number for preterm birth when looked at by all races. For those who were at the annual meeting back in 2018, Dr. Barbara Osfeld from the SID Center had referenced an article about New Jersey in terms of infant mortality. This slide is preterm birth, but in terms of infant mortality, that stated essentially about intervention and programming related to infant mortality. These lines of race would not converge, meaning that those disparities, racial ethnic disparities between Black and white infants will not change in the direction, with the direction that we're heading now. There needs to be intervention in multiple forms to affect that infant mortality rate, to decrease Black infant mortality rate. Next, please. Next slide, please. So how does this impact the families that you work with? Next. So what has shown success? Speaking of data, we have data that shows how different programs have been able to impact data and numbers. So we use that data to determine which type of programming will work the best on the problem that we are trying to ameliorate. So of our programs, we see that the following have shown success: home visitation, very successful; stress reduction and coping strategies and techniques; early childhood initiatives, very, very successful; wraparound services, education, employment, and other types of services, many of which we conduct at Central Jersey Family Health Consortium, have shown to have a positive impact on health overall and also reducing adverse maternal child health outcomes. Next, please. So here we see our umbrella again. Where do our maternal child health programs fit? So in order to decrease infant mortality, you must decrease the rate at which babies are born with genetic malformations, low birth weight, and preterm birth babies. We come in by addressing the short-term problems that will have an impact on addressing the intermediate-term problems and ultimately making a difference in the big problem. As I mentioned earlier, we provide services in the community that you can see up here: teen pregnancy prevention, services for perinatal addictions. Over here on the other side, we see peer mentoring, social factors, healthy women, healthy families. Those are, positive programs seeking positive change. And they also have an impact on reducing preterm births, and by reducing preterm births, we can reduce infant mortality rates. Again, all of these fall under the umbrella of data, and without vital statistics, we cannot accurately target programming that will have the largest impact on our communities. And that's data collected on both sides. That's data collected on the births occurring in New Jersey and babies growing up in New Jersey, and that's data on our own programs too, to show where our impact and where our reach has been by showing data from our findings. Next. I believe that's the last slide, so I wanted to open it up for questions.
Right now, if there aren't any questions in the chat room, you can type them in, please.
Okay, it looks like Dr. Please having some issues with seeing the questions. There is a question for you, Carly.
Okay.
If you have occupational stress closer to the due date of the delivery, could it cause early labor?
So I'm not a clinician, I'm not a physician or a nurse. So I'm not sure that I can give a true answer on that, but certainly occupational health during pregnancy can potentially lead to episodes of preterm labor, yes. Physical work, accidents, trauma, stress, these things can all be at play in a situation like you are describing there.
Any other questions for Carly?
Here's another question. Has any data come out from 2020 yet?
Any data from 2020, we have been able to get our hands on some very preliminary data from 2020, trying to look at some of the different adverse outcomes in light of the pandemic. That data is not publicly releasable, and I don't believe that we have the entire year of 2020, but hopefully we'll be getting it soon. Is there a particular data that that person was looking for that I might be able to help? But 2020 data will not be publicly available from the Department of Health, I don't think, until next year, until 2022.
Carly, I have a question. How do you all gather all this data? Where do you get all your data from?
So our primary set of data is the vital information platform, or the VIP data, which is the birth certificate data. So after the electronic birth certificate system was out, we got a new system called VIP. And the consortia, through the regulations, DOH's regulations for the consortia, have access to VIP data. We have access to the VIP data in our region only. So when I said that we had some data for 2020, that would be only in the central region. When the data is blessed by DOH, so to speak, or finalized, it's available on a website so everyone can access it, which is called New Jersey SHAD, S-H-A-D, State Health Assessment Data, I believe is what NJ SHAD stands for. But you can actually, anyone can go on and look at some of the prior year's data. They typically run about 2 years behind. But we get the data anywhere between monthly and annually from the Department of Health, and also from our hospitals, and we reconcile those lists. So most of the data presented in this would have come either from the vital information platform data that we get ourselves, or from the NJ SHAD, which would be where we would access statewide data. Does that answer your question, Trish?
Yes, thank you. Do you think there's going to be some trending data in COVID and maternal health and infant health coming out soon?
I would like to see that. I have not heard that that's happening, which does not mean it's not. But I imagine that there will be quite a lot of data coming out as we get a little further out from 2020, looking at the changes relating during the pandemic. But I'm not aware that's going to be released soon.
Okay, thank you.
And I have another question. Does the data show us anything that can be done to increase the birth rate?
The data does not show us anything that can be done to increase the birth rates. No, unfortunately, it doesn't. We just know what the birth rates are.
And one other question, when you have all this data, who then takes the data and starts trying to kind of brainstorm on strategies and plans and interventions to improve the data?
To improve the data, Trish?
Yeah, like who's actually responsible for that?
So the consortium is somewhat responsible for that. Again, in our DOH regulations, we are required as an organization, as a maternal child health consortium, to provide technical assistance and user support for the VIP system. So we've got 14 member hospitals, all of which have, used the VIP system to capture their births. So we do work with them and have periodic meetings on quality of data where we discuss identified data quality issues. We ensure that the different hospitals are using the same consistent data definitions. And then we advocate on behalf of the hospitals and the consortia and other community-based organizations for changes or improvement in data in the VIP system. Unfortunately, the way the VIP system works, it's not an easy fix to just go in and add something. But we do work with the Department of Health on ensuring accuracy of that data and expanding the data when possible, like, for example, now with COVID.
Great, thank you.
Next question, are things like home births included in the data?
Yes, a lot of the home births are in the data because typically the birth gets registered so that the parent has a birth certificate and can get a social security card for the child. So yes, we see with a lot of home births that they will not be born at the hospital, but that there will be a delivery record there. So we do get some of that information, if not all of it, yes.
Is there a way to distinguish births that happened in New Jersey but were from people that are traveling?
Residents? Yes, we can.
Non-residents.
Yep, we can look at the state that they live. We usually, for our purposes and for our programming purposes, look for folks that are from New Jersey. But for certain programs, we want to, rule out that they're not out of state. So yes, that is captured, and we do have the ability to look at how many women deliver in New Jersey that don't live in the state. And we can look at addresses. So for example, it's not that surprising to see a woman from Pennsylvania or New York to deliver in New Jersey. But if somebody were to be here from California, we could make an inference that that was a woman traveling.
And also, Carly, so this is going on at the central part of the state, but it also goes on in the northern part of the state with the partnership, and then the southern part with the Southern New Jersey Perinatal Cooperative, correct?
Yes, correct. So the 3 Child Health Consortia all have the same charges in terms of working with Vital Information Platform, working with our hospitals. Each of the other two consortia have access to their own region's data. And we do have statewide meetings sometimes to come together and discuss things that have been concerning or things that we'd like to see. So we do get a statewide perspective. And we typically find that a lot of the issues, are consistent throughout the state. They're not region specific. But yes, they also have the same planning processes, also having a continuous quality improvement committee that also uses the data to look at certain maternal child health indicators and have conversations about how to improve some of those indicators should they be problematic.
Great, thank you.
Next question. What is the relative risk, so to speak, from factors present before pregnancy versus what happens during pregnancy when it comes to both maternal and infant health outcomes?
Let's see. I might ask Trish for a little help on this one.
You know what, Kim? Actually, the question's a little confusing to me. Are you asking what's the difference between those that happen in the antepartum period versus those that happen in the interpartum period?
Let's see if the questioner will clarify.
Okay. I mean, if you're looking for, when we look at maternal deaths, for example, we do know that the majority of maternal mortality occurs in the postpartum period. And that's not only in New Jersey, but it's also national. So we do know we can look at timing of maternal deaths. We could look at timing, obviously, of infant and fetal deaths. But again, I'm not sure about what comparison you're looking for.
I think the way I understood it was the question was asking, what's the relative risk of a stressor happening prior to pregnancy versus during a pregnancy? Does that sound correct?
We have a response from the person who asked the question originally. I'm wondering about women who enter a pregnancy with health risks versus health risks that develop during pregnancy.
So what's the relative risk ratio? I wouldn't be able to answer that question, unfortunately. Again, so many variables come into play when you're talking about risk, and also when you're talking about what health-specific behaviors are involved with each woman's care. So it could be that a woman that comes in with a list of health issues may actually have a better outcome than somebody came in with no risk factors, but we develop them during the interpartum period, for example. It would also come into play with what outcome are you talking about? Did they have a better birth outcome, infant outcome, maternal outcome? Again, we know that women who are high risk tend to have a higher risk ratio with regards to the possibility of having a worse outcome. But that's not always statistically in sync with each other.
Okay, next question. Is there research and data that conclusively shows that the mother's increased stress and anxiety could affect the baby?
There is research out there. They've done a lot of work on stress, and they, I know Dr. Susan Gennaro has done work on this. If you were to do research on this, you will find that they've really been able to study stress as a variable, as an indicator to contributing to poor infant outcomes.
Can you explain the big data slide 3, which explains the rationale of collecting?
Slide number 3.
Data slide 3. I think it's the next one.
I think it was the one that you just had. So the rationale for collecting data, what would be that we collect data on each of these aspects. And at times these data are used to write grants or needs assessments or other materials which will determine how much funding an area might get for a program, for example, Healthy Women, Healthy Families. So we collect information on all of these, and high rates of low birth weight babies and preterm births in Trenton, perhaps higher uses of tobacco use. Those would all be pieces of information that feed into giving a picture of a community and being able to apply to create or receive funding for a program that helps address those specific issues. So again, for the tobacco use, we have the smoking cessation program. For low birth weight and preterm birth, we have programs like Healthy Women, Healthy Families, stress reduction, some social support, a variety of other factors that might help a mother to relax and ensure that take the best care of herself from a stress level so that perhaps she won't have stress-related health complications. I'm not sure if that quite answers the question or not. And then we would collect information. So we would know the infant mortality rate, collect information, and then go back and see, has the infant mortality rate changed? So we can do these smaller tests of change as we try to figure out what exactly is positively affecting a particular outcome. So we know, for example, that tobacco use is associated with preterm birth and also low birth weight. So that may be one of the driving factors in terms of low birth weight income or low birth weight births.
And we got a yes, that answers my question, and thank you.
Thanks. Well, I appreciate all of your help and everyone coming on today and listening to my presentation. If you do have any questions, my name is Carly Ryan. I am at Central Jersey Family Health Consortium, and please feel free to reach out to me anytime.
Great, thank you so much, Carly. This was a great information session, and we appreciate your time so much. Thank you all for joining us today.
Thank you.